Hi, so today we're going to talk about the pleura. Um, this is a series of lectures for undergraduate medical students. So, as you probably know, the pleura is formed of two layers, the parietal layer, which is the outer layer, and the visceral pleura. And usually there is a small amount of pleural fluid present in the space, usually around 10 to 20 milliliters. When there is a collection in the pleural space, it results into pleural effusion. And do not confuse between the pleural effusion and the pleural pulmonary edema. Pulmonary edema is fluid within the alveoli of the lungs, with sometimes with patients with heart failure, for example. Whereas the pleural effusion is a different thing. It is the presence of effusion on the pleural space outside the lung. So usually there are driving forces to maintain this 10 to 20 mL of pleural fluid to allow for lubrication and sliding of two layers of the pleura. So usually this amount of fluid is filtered through the systematic vessels or pulmonary vessels in the pleural space. And there's also an opposing force, which is the oncotic pressure, which pulls the fluids away. So the net driving force is a small amount of fluid which is only needed for lubrications and easy sliding of both layers. So we have two types of pleural fluid. It's either transudate or an exudate. So if we think about transudate is an increase in the hydrostatic pressure. So this could be either from the heart failure or liver failure or patients with hypoampolemia. So there will be less oncotic pressure driving the fluid outside the pleural space. So these are renal failure. So these are the pleural fluid will be, or pleural effusion will be part of anasacra or generalized effusion of fluid in the body due to the increase of hydrostatic pressure or decrease in oncotic forces. The other type is the exudate. So the exudate is another entity. So this will be morely local to the pleural space and the lung and the surrounding lung. So this could be either due to infection like parapneumonic effusion, which might also result in empyema later on. There is also autoimmune disorders which cause exudative lung pulmonary pleural effusion. It could be also tumors, whether they are primary or secondary metastasis, metastatic like mesothelioma, primary pleural tumor, or metastatic or primary lung cancer or metastatic lung cancers. Also pulmonary embolism or pulmonary infarct, which leads also to an effusion due to irritation and occlusion of the air of the blood vessels supplying this area. Also hemothorax, which is traumatic or iatrogenic, and there's also it might also be due to an extension from the subdiaphragmatic from the infradiaphragmatic collection, like patients, for example, would have subphrenic abscesses or pancreatitis. Or it could be due to esophageal perforation, or patients who also might have a chylothorax, which due to injury to the thoracic duct, or drug-induced or idiopathic causes. So the clinical picture, if there's a small effusion, it could be asymptomatic. The patient might not present with symptoms. When it is large enough to cause to be a large effusion, then it might present with shortness of breath, sometimes chest pain, chest discomfort. If it is a massive effusion, which might lead to the mediastinal shifting, then it will resemble the clinical picture of the tension pneumothorax. So on examination, you might find some evidence of the underlying cause if a patient is presented with respiratory problems suggestive of pneumonia. If the patient is having an autoimmune disorder, you might have this manifestation seen. And then we'll go through the local examination. So with auscultation, you'll find a measured breathing sound, and on percussion it will be dull, and you will find the signs and symptoms of the underlying cause. So the most common investigation will start with the normal routine labs, and also we will direct the lab assessment towards the cause. If we are suspecting autoimmune disorders, or if we are suspecting infection, then we will request the specific lab investigation. And then we will do a chest x-ray, which is a rapid assessment for pleural effusion. You might also give an incidence or give a hint about the causative factor. You can find rib fractures if a patient having a trauma. If you can find a mass, if there's a lung cancer or metastases, you can also find infection. evidence of consolidation, which may be the underlying cause, or a collapse of the lung, or areas of infarct. So you can have also, it will give you some idea about the causative factor. The chest X-ray picture will depend on the amount of the collection available. So if there is the obliteration of the cosophrenic angle requires around 300-400 mL of fluid, the chest X-ray might not pick the small amount of effusion. It might be better to assess with the ultrasound or CT scan. If you would like to assess the difference, or if you would like to assess whether the collection is free-flowing or loculated, like in patients with empyemas or chronic, where there's a neglected parapneumonic effusion or neglected hemothorax, then you can do a free lateral decubitus film. So as you see here, this is a pleural effusion with, you can obliterating the cosophrenic angle and even much more. And as you can see here, you can appreciate the acute angle, the normal sharp cosophrenic angle, and then you can assess the smallest amount of effusion. So if you do lateral, if you ask the patient to lie on his side, then you can assess whether this is a free-flowing or loculated collection. So if you see here, this is a CT scan, this is a pleural effusion, and the patient is erect or standing position, and then you can see that the fluid is in a position which is not gravitational, so it's not dependent, though the patient is already standing. So this indicates that this area of collection is also is loculated. So there is a loculated collection that keeps the fluid in this position, which is not gravitational. And here as well, you can see there's some collection which is present if the patient is lying on his back. The collection, if it is free flowing, it should be lying all in the posteriorly. However, this area is hang there because there's loculation. So CT scanning and ultrasound will give more robust idea about the cause and the extent. So it will assess the pleural effusion, the underlying and the associated intrathoracic pathology, and localize the fluid prior to thoracocentesis. And this will help you also for biopsying if you need biopsy or surgery. As you can see here, there is the thoracocentesis. So when we obtain the pleural fluid, we have to send them for cytology, for biochemistry, and for microbiology, for culture and sensitivity. And this will help to direct the antibiotic choice based on the culture and sensitivity. So biochemistry, this will help us to, initially, the gross appearance of the fluid will give you an idea. So if it is a traumatic, you will find the blood. If it is serous changes, it could be more of malignant, or if it is whitish, it may be a chylothorax. If it is turbid and yellow, then it will be empyema. So the gross appearance itself might help to direct you to the causative factor, to the underlying cause. The biochemical assessment, there is little criteria which will help to differentiate between transudate and exudate. So what we usually assess in the pleural fluid is a total protein, LDH, glucose, and pH, as well as amylase, triglycerides, and other factors which could be related to the autoimmune disorder. So we first assess the presence of the ratio between the pleural protein to serum protein. So if it is more than 0.5, this is an exudate. And also the LDH, if the ratio for the pleural LDH to the serum LDH is more than 0.6, it's an exudate. If the pleural LDH is more than 2/3 of the upper limit in laboratory level for the LDH, is also an exudate. The glucose, if it is low, that will suggest malignancy or TB or parapneumonic effusion or rheumatoid effusion. If it is a low pH, low than 7, this will suggest that the patient will usually progress to empyema. Amylase will be also elevated in patients with esophageal perforation and pancreatitis. Triglyceride will help to diagnose the chylothorax. If we are suspecting autoimmune disorder, then we can do the antinuclear antibodies and the other panel for autoimmune disorders. So what is the treatment of recurrent pleural effusion? So recurrent pleural effusion could be due to malignancy, whether it is primary or metastatic, or could be also primary lung cancer or metastatic. So for this causes, when we are not treating the main cause of the pleural effusion, we're trying to do palliative treatment to prevent patients or to help the patients who have to improve the quality of life. We will need to do to decompress the pleura in order to decrease the symptoms. So we can insert a chest drain initially. We can also do serial thoracocentesis, which is repeated tapping. We can also insert a pleural catheter if we are suspecting that this will be a long-standing condition. So we can do a pleural catheter or Pleurex, and this is a catheter, indwelling catheter, which can stay up to 1 year, and then it allows the evacuation of the fluids. So then the patient may come to the hospital or being visited with a cystoscope nurse, and then we evacuate it almost every week. And then we also can do a pleurodesis. So if we are not certain about the underlying pathology, we can do a pleural biopsy and through a VATS or an open. And then we can also do a talc pleurodesis, or depending on the different agents used in different centers, we can do pleurodesis. And this is a creation of a sterile inflammation in the pleural space, and this will help to try to create a scar tissue and inflammation and bring these two layers to stick together and help the lung, help to reduce the recurrence. The Pleurex, or the indwelling pleural catheter. So what's empyema? Empyema is a pus in the pleural space, which could be localized or involving the entire pleural space. So usually it could be from a contamination from the parapneumonic effusion or infection in the lung itself that cause the extending to the pleural space. It could be also a neglected hemothorax in patients with chest trauma or rib fractures. It could be also rupture of the lung abscess. It could be extension from mediastinitis, whatever the cause. And also it can be spread from the abdominal content to the diaphragm, or it could be hematogenous spread from elsewhere, like any other things in the body. So this is a lung abscess causing pus, rupturing, causing pus in the pleural space. There's odontogenic abscess, patient who have infected endocarditis, for example, or whatever, and then they will spread through the body. The pathogenesis, first there is the parapneumonic effusion, and then it will progress through 3 stages. Initially, there will be an exudative stage, and at this stage, there will be a thin pleural fluid due to increased pleural permeability and inflammation of the pleura, and this thin fibrin is deposited in the pleural space, and which means that if the pleura is drained, the lung is able to re-expand because it's very early and this is not thick, purulent collection. When it is more progressed, if we pass this stage, the fibrin and purulent stage then will come. So there will be a bacterial inoculation and invasion of this collection, and will be an influx of polymorph, and the fluid will become more thick and more turbid and more purulent, with heavy fibrin deposition preventing the lung from re-expansion. And then later on, if this is neglected, there will be an organization stage when the pus becomes very thick, forming a thick pleural peel, and this thick pleural peel will trap the lung, preventing it from re-expansion, because now there's a collagen deposition. So the organisms which are incriminated on the development of the empyema is aerobic, gram-positive, strep and staph, and gram-negative, coliform, and anaerobic bacteroids and fusobacterium. So as you can see here, this is the trap. This is the empyema collection, and there's a trapping of the lung in the chest wall, unable to re-expand even if you insert a chest drain, because now the problem is that the lung itself is trapped because of the thick pleural peel. So what are the complications of untreated empyema? So because there's a collagen deposition and the growth of fibroblasts, there will be pulmonary fibrosis, which will cause traction and contraction of this scar tissue, which will cause skeletal deformities or chest wall deformities. And sometimes there is a rupture or extension of this pus through the chest wall, causing empyema necessitans, like giving a picture of the chest wall abscess, but it's connected to the chest, to the empyema cavity, or through the bronchial tree, causing bronchopleural fistula, or local spread to the pericardium or mediastinum, causing mediastinitis or pericarditis, or distant infection through the blood, causing osteomyelitis. So this is a skeletal deformity following long-standing empyema and frozen chest. There's also, this is the extension of the pus to the chest wall to the chest cavity, from the chest cavity, causing empyema necessitans. So what will be the treatment? So generally, we have to treat the underlying cause, the associated medical conditions. Patients could be immunocompromised, and then we would start with wide-spectrum antibiotics, and they will be directed by the cultural sensitivity from the pleural sample that we've sent earlier. The drainage, we will start with thoracentesis. without pleural drain, which is not recommended because the pleural fluid is very thick and it will not result in complete evacuation of the fluids. So either closed drainage onto water seal, or in some patients might have small pore drain placements. It's also worth mentioning that in some centers there might be intrapleural fibrinolytics, which can be introduced through the drain. If you refer to MIST 2 and MIST 1, MIST 2 trials, you can find the results for using of DNase and alteplase, which are agents to help to lyse or to break down the adhesions, but these are reserved in early stages, like fibrinolipid stage, with some sort of success. In patients then who have a chronic space where the lung is totally trapped, and then we can do thoracoplasty. So the thoracoplasty is some sort of palliative treatment, try to create a space and bend into drainage so this pus will not retain in the chest cavity. And we can also do a decortication in earlier stages, which could be VATS, wash out. If there is a debridement, we can do VATS, wash out, and debridement of the fibropyrrolin deposits, if this is an early stage. Or later we can do also decortication to remove the thick pleural beer and allow the lung to be untrapped and re-expand again. And that's when we do reprosection to try to create a more window to help the drainage, the bendited drainage of the empyema cavity. There are different sorts of flaps. They are all trying to maintain a dependent position for continuous drainage of the empyema cavity. They cause reprosection and try to bring the chest wall close to the lung. So we try to obliterate or decrease the space. So as you can see here, this is the empyema cavity and this is the thick pleural peel. So that's the right side thoracoplasty. As you can see, we are trying, if the lung is unable to go to the expand to the chest wall, try to resect some lungs to allow the drainage and bring the chest wall closer to the lung. Chylothorax is the abnormal accumulation of the chyle due to injury of the thoracic duct in the pleural space. It could be traumatic with penetrating injury. It could be post-operative in patients with cardiac surgeries or thoracic surgeries, like patients with thymomas, for example. Patients can also have after neoplastic disorders with malignancies in the posterior mediastinum and invasion of the thoracic duct, and it could be other causes. So usually the patients have milky chest drain output, and usually it is increased when patients have an oral intake with fatty diets. Patients then will if the patients are not presenting with chylothorax postoperatively, then non-operative patients will have dyspnea and physical radiological evidence of pleural effusion. So as we mentioned before, with rock synthesis and sending the pleural fluid analysis, we can ascertain from the gross appearance and from the triglyceride amount that this is a chylothorax. And also we can do radionuclide scanning and lymphangiography, and sometimes CT scanning, I think, is one of the best evidence, the most helpful tool to assess the causative factors if we are not sure about the malignant invasion of the trauma. The treatment is usually conservative, so patients will be MPO. We have TBN, which is total parenteral nutrition, fat-free diet, and medium-chain fatty acid supplements. And sometimes in some centers they might give somatostatin, which will help to decrease the output of the drains and decrease the output of and help to improve the outcomes and in the healing of the thoracic duct. In the failure of the previous measures, we can do right thoracotomy or thoracoscopy to do direct ligation of the or mass ligation of just above the diaphragm. Sometimes we can help to determine the place of the thoracic duct with administration of cream prior to the operation to see to be able to visualize the thoracic duct. And also in some centers, with the high output, they can go straight to surgery in patients with high output drain because these patients will be immunocompromised. As you can see, this is the mass ligation of the thoracic duct. So let's talk then about mesothelioma. Mesothelioma is a tumor arising from the mesothelial linings, which can be present in the pleura and peritoneum. The types of pleural mesothelioma is either localized or diffuse. So usually the localized type is not related to the asbestos exposure. It's the well-encapsulated tumor. Patients could be presenting with chest pain and cough. Diffuse type is usually always malignant and is associated with asbestos exposure. So the asbestos fibers can result in the plaques, which can be previous or prior to development of mesothelioma, and can also have mesothelioma. So asbestos is one of the major causative factors or known risk factors for mesothelioma. The clinical picture is usually chest wall pain. Patients have weight loss and cachexia and fever, as well as dyspnea. And when we do a CT scan or chest X-ray, you can find an effusion and also the pleural thickening. With pleural fluid samples can give an idea about having atypical cells. However, we might need to do a pleural biopsy in order to establish the diagnosis and confirm the diagnosis. This can be done either with biopsy, corpus tissue biopsy, or a thoracoscopic or open pleural biopsy. And this will also help to place a drain or do a pleurodesis, like a pleurex drain or talc pleurodesis, to prevent the recurrence of the patients having a recurrent pleural effusion. The pathological type is the epithelioid, sarcomatoid, and mixed type. So the treatment is usually radiochemotherapy or immunotherapy. Surgery is limited to being palliative and diagnostic, with obtaining a pleural biopsy and talc pleurodesis or insertion of indwelling catheter. Pleurectomy and their cortications is difficult and palliative. It's not curative surgery. External is an in-block resection of the pleura with the lung and diaphragm, as well as the pericardium. As you see, it is a massive surgery. The mortality rate is high. Patients might not be unoperable patients. Combined modality treatment, including surgery, combined with radio and chemotherapy, is in selected patients, and there are several studies assessing the treatment or the proper management for mesothelioma. As you can see here, this is the thickening of the pleura. Usually, the thickening related to the mediastinum to the mesothelioma is the mediastinal thickening, and that's what the patient will have. Also, the main presentation is also chest wall pain and dyspnea. That's the end of the lecture. If you have any questions, please do not hesitate to contact me. Thank you.